Imagine you are just washing your face one morning, right? And right there, just in front of your earlobe, you feel something.
Like a little lump.
Exactly, a lump. It is small, maybe entirely painless, but you are absolutely certain it was not there yesterday.
Which is, a terrifying prospect for anyone.
Oh, for sure. You go to the doctor, and what follows is not just some simple outpatient extraction. It is the beginning of this incredibly delicate surgical puzzle.
Because the doctor has to extract a tumor from tissue that is intimately tangled with the nerves controlling, well, every single expression on your face.
Right. The terrain we are talking about is intensely unforgiving. The stakes are not hidden away deep inside the body. They're written right across your face.
Yeah, a fraction of a millimeter can literally mean the difference between a normal smile and permanent facial paralysis.
So today we are taking a deep dive into parotidectomies. That's the surgical removal of the parotid salivary gland.
We're going to explore both superficial and deeper sections of this gland, really unpacking the mechanics of how doctors navigate this space.
The goal today is to explore this high-stakes tightrope that head and neck surgeons walk. I mean, they have to balance the absolute biological necessity of eradicating a tumor with the delicate preservation of the facial nerve.
Exactly. We will decode the physical clues surgeons look for, trace the historical evolution of the surgery, and look at the frankly bizarre ways the human body rewires itself after going under the knife.
Okay, let's unpack this. To really understand why this surgery is such a massive undertaking, you first have to understand the strange anatomy of the parotid gland itself.
It's the largest of your major salivary glands. It sits right there on the side of your face, wrapping around the back of your jaw.
But the biggest shock to me in the sources was discovering that the parotid does not actually have distinct lobes.
Right, you always hear terms like superficial lobe and deep lobe.
Yeah, but that division is completely arbitrary.
It really is. It is a brilliant example of how medical terminology sometimes reflects, surgical necessity rather than pure innate anatomy.
So it's actually just one single continuous mass of glandular tissue.
Yep. The only reason surgeons divide it into superficial and deep zones is strictly because of the facial nerve.
The one that originates in the brain and controls your ability to blink, smile, frown, all of that.
Exactly. That nerve runs straight through the middle of the parotid tissue. Roughly 70 to 80% of the gland sits above, or lateral to, this nerve.
So anything above the nerve is deemed the superficial lobe, and anything below it, closer to the skull, is the deep lobe.
You got it.
I mean, operating on the parotid isn't like removing a discrete, self-contained organ like a kidney. It is like trying to remove a block of wet concrete while carefully preserving a highly delicate fiber optic cable that is running right through the middle of it.
I love that analogy. And for a very long time, surgeons just did not have the tools or the comprehensive anatomic mapping to protect that fiber optic cable.
The historical cost of ignorance here was incredibly high.
It was brutal. If we look back to the early pioneers, like John C. Warren at Massachusetts General Hospital in 1846, he performed the first parotid tumor resection under ether anesthesia.
But the result was serious facial disfigurement.
Yeah. Early surgeons simply carved out the mass as fast as possible. They didn't have microsurgical instruments.
And they didn't fully grasp that the facial nerve branches out through the gland like a sprawling spider web.
Right. If they took the tumor out, you were losing your facial function. It was a package deal.
And for decades, that was just the grim reality of the procedure.
It really was. I mean, surgeons in the late 1800s and early 1900s started making anatomical strides, mapping out the space. But the real turning point didn't happen until W.E. Sistrunk at the Mayo Clinic in 1921.
What did he do differently?
Well, he firmly advocated that surgery was the only cure for a parotid tumor. But more importantly, he introduced a deliberate technique aimed at identifying and preserving the facial nerve before removing the tissue.
But even with a pioneer pushing for nerve preservation, it took a long time to become the standard, didn't it?
Oh yeah, it took a massive landmark study to change the everyday standard of care. The Mayo Clinic eventually published results comparing a 15-year period from 1940 to 1954, where surgeons mostly used simple, local resection.
Basically just plucking the tumor out.
Exactly. They compared that against a second 15-year period from 1955 to 1969, where they systematically identified and preserved the facial nerve while doing a formal parotidectomy.
And the data was undeniable.
Completely. Preserving the nerve while meticulously removing the surrounding glandular tissue drastically reduced both the recurrence of the tumors and the incidence of facial paralysis. It became the undisputed gold standard.
So bringing it to the modern day, before a surgeon even makes an incision, they have to act as medical detectives.
Because going in blind is disastrous. That nerve runs right through the tissue.
Right, so they have to decode the lump first.
The first piece of the puzzle is purely statistical. The good news for anyone finding that lump is that approximately 85% of parotid neoplasms, or tumors, are completely benign.
Okay, that's a relief. What are the most common benign ones?
The most common are called pleomorphic adenomas, which are slow-growing masses made of mixed cell types, and Werthin tumors, which are often fluid-filled cysts.
But the malignant tumors are the real nightmare scenario here. What are surgeons most worried about finding?
Statistically, the biggest threat is something called mucoepidermoid carcinoma.
That sounds intense.
It is. A massive SEER database review of over 22,000 cases showed that this specific cancer is the most common salivary gland malignancy. It makes up roughly 31% of those malignant cases.
And it can be highly aggressive, which is why the physical examination is so critical. A surgeon's hands can tell them a lot.
Absolutely. If the mass is mobile, meaning it slides around a bit under the skin when pressed, that is usually a strong indicator that it is benign.
And what about the Werthin tumors?
Well, if a patient comes in with a long history of smoking and presents with a squishy cystic parotid mass, the detective work points heavily toward a benign Werthin tumor.
But if there is pain, or if the lump is growing rapidly, or if the patient already has existing facial paralysis when they walk into the clinic.
That is a huge red flag.
Yeah, that means the tumor has likely already started invading and destroying the facial nerve.
Exactly. Once they evaluate those physical clues, they immediately move to imaging. CT scans, and especially MRIs, with contrast dye, are vital.
What are they looking for on the MRI?
On certain MRI scans, malignant tumors show up as dark, dense voids, Radiologists call it low signal intensity on a T2 weighted image,
Why are they dark?
because they are packed tight with rapidly dividing dense cancer cells rather than the normal, brighter fluid you would see in healthy tissue or a benign cyst.
Well, that makes sense.
And malignant tumors also behave differently with the contrast dye. They absorb the dye earlier and hold on to it longer than benign tumors do.
Okay, I have to push back on a specific diagnostic tool used before surgery. Often, doctors will use a fine needle aspiration or an FNA biopsy to poke the tumor and sample the cells.
Right, very common.
But the sources mention that an FNA has a 10% false positive rate. With a margin of error that high, why on earth would a surgeon rely on a needle poke before deciding to undertake such a risky, nerve-exposing surgery?
What's fascinating here is that surgeons share that exact skepticism.
Oh, really?
Yeah, they do not use the FNA as the absolute final word to plan a radical, nerve-sacrificing surgery. But the FNA is incredibly useful for vulnerable patients.
Give me an example.
Imagine an 80-year-old patient with a severe heart condition. If the FNA comes back indicating a benign wart and tumor, the doctor might decide to just observe the lump over time.
Rather than risking putting that frail patient under general anesthesia for a grueling surgery.
Exactly. The FNA provides a highly educated guess that guides overall risk management, deciding if they should operate at all. Plus, surgeons use frozen section analysis during the actual surgery.
Which is much more accurate, right?
Yes, it has a lower 5% false positive rate. They use that to confirm the diagnosis before they ever decide to sacrifice the nerve.
Yeah. So the frozen section comes back clear, the patient is asleep, but the surgeon still can't actually see this microscopic nerve hidden inside the gland. How do they physically make the first cut without flying blind?
It starts with an incision designed to hide the scar. It's commonly called the modified Blair incision.
That starts near the ear, right?
Yep. The surgeon cuts starting right near the front of the ear, tracing down behind the earlobe, and blending into a natural crease in the neck.
And then they peel back the skin.
Right. They carefully peel back the skin and elevate a layer of tissue called the SMAS flap. That stands for the superficial musculoaponeurotic system.
That is quite the mouthful.
It is.
Yeah.
But they keep this thin layer of muscle and fascia intact so they can fold it back later. It helps fill in the dent left by removing the parotid tissue, preserving the natural contour of the patient's face.
But once they are inside, they still don't magically see the facial nerve. They have to rely on raw, tactile landmarks.
Because soft tissue shifts and moves during surgery, a surgeon has to anchor their navigation to things that do not move, like bone and cartilage.
Right. So what are they feeling for?
Well, they run their finger along the rigid cartilage of the external ear canal until it reaches a sharp point. This is called the cartilaginous pointer, and it literally points toward the danger zone.
That is so wild. And they also palpate the tympanomastoid suture line.
Exactly. This is a tiny physical groove in the skull where two bones meet. You can literally feel it like a crack in a pavement.
They also locate the posterior belly of the digastric muscle in the upper neck, because the facial nerve always exits the skull exactly near these rigid bony and muscular landmark.
And once they find the main trunk of the nerve exiting the skull, they have to carefully follow it as it branches out through the gland.
And there are strict rules for this. Dissection must always be parallel to the nerve fibers.
Right, because the branches of the nerve spread out like the limbs of a tree. If a surgeon cuts perpendicular to the trunk, they run the massive risk of snipping a branch clean off.
Oh, wow. And the anesthesiologist has rules too, right?
Yes. They're strictly forbidden from using any long-acting paralytic drugs on the patient.
Because they need the face to be able to move during the surgery.
Exactly. The surgeon uses a tiny electrical probe to stimulate the tissue as they work. If they're close to the nerve, they can literally watch the patient's face twitch under the surgical drapes.
It provides instant, real-time feedback that the nerve is alive and intact.
It's incredible.
Here's where it gets really interesting to me. Think of the intense irony of modern medicine here.
How so?
We have harmonic scalpels that use ultrasonic vibrations to cut and seal tissue simultaneously. We have high-tech MRIs utilizing immense magnetic fields, but at the absolute critical, life-altering moment of this surgery.
It comes down to a highly trained surgeon literally feeling around in the dark for a tiny, bony groove in the skull to guess where a microscopic nerve is going to emerge.
Yes, it is the ultimate fusion of modern technology and classical, tactile, anatomical mastery.
It truly is. But finding the nerve when the tumor is sitting comfortably on top of it in the superficial lobe is one thing.
Right.
The complexity multiplies exponentially when we talk about the deep lobe. What happens when the tumor is hiding beneath the nerve, wedged deep against the base of the skull?
That is the dumbbell dilemma. As a deep lobe tumor grows, it has nowhere to go but outward toward the skin. So it physically pushes the entire facial nerve outward, stretching the nerve tight over the surface of the tumor.
And before they even make an incision, doctors can sometimes spot this on an MRI. There is a blood vessel called the retromandibular vein that normally sits deep inside the gland.
And if the tumor is deep?
If the MRI shows that vein visibly displaced, laterally pushed outward toward the skin, that tells the surgeon the tumor is deep, and the delicate facial nerve is going to be stretched paper thin right over the top of it.
And the space deep inside the jaw is incredibly cramped. There is an anatomical bottleneck called the stylomandibular tunnel. It connects the deep parotid area to the parapharyngeal space.
Which is essentially the side of your throat.
Right, so if a tumor grows through that tight tunnel, it gets squeezed in the middle and expands on both sides.
Creating a literal dumbbell shape. Part of the tumor is in your cheek, and part of it is bulging into your throat.
To safely extract a tumor that spans two entirely different anatomical zones without tearing the facial nerve draped over it, that requires extreme access.
A standard neck incision will not provide enough room. The surgeon might have to sever the skylomandibular ligament to open the tunnel. They might have to cut the digastric muscle.
And there are specific rules even for that.
Yes. If they cut through the muscle fibers themselves, the muscle will not heal and function again. It has to be cut at the tendon, the ligamentous portion, if they ever want to sew it back together successfully.
And in the most extreme, massive deep lobe tumors, they actually have to perform a mandibulotomy.
Yeah, they literally saw through the jawbone to swing the mandible out of the way just to get their hands into that deep parapharyngeal space.
The level of structural disruption is just profound.
Often, to achieve that access, they're forced to sacrifice a sensory nerve called the great auricular nerve, which provides feeling to the earlobe and the side of the face.
But a severed nerve doesn't just stop working, right? It tries to heal.
It does. And to prevent a painful neuroma from forming, which is when a severed nerve end bundles up into a highly sensitive, painful ball of tissue, the surgeon will carefully bury the live, cut end of the nerve deep into a nearby muscle.
Essentially tricking it into stopping its chaotic growth.
Exactly.
With all this jaw sawing and muscle cutting, what happens if the deep lobe tumor is malignant? Do they just take the facial nerve out with it to be safe?
Well, if we connect this to the broader philosophy of oncology, there is a critical directive in parotid surgery. Even if a deep lobe tumor is confirmed to be malignant, the surgeon must try everything to preserve the facial nerve.
Everything.
Yes. The only exceptions are if the nerve is visibly, physically encased by the tumor mass, or if that frozen section analysis proves the cancer cells have aggressively infiltrated the nerve fibers themselves.
Because microscopic cancer cells left behind on a preserved nerve can be treated later with targeted radiation therapy.
Right. But a deliberately severed facial nerve alters a person's life forever. You cannot radiate away a severed nerve.
The functional and psychological impact of losing the ability to smile or close your eye is just devastating.
So preservation is paramount. But even if the surgeon executes this high-wire act flawlessly,
Right. Even if they remove the tumor entirely, save the nerve, and close everything up beautifully.
the sheer disruption of the parotid tissue causes the body to rewire itself in some truly bizarre ways during the recovery process.
The aftermath. This is where the biology gets genuinely weird. One of the most common complications is Free syndrome, also known as gustatory sweating.
Up to 60% of patients experience this after surgery.
60%.
It is a fascinating consequence of the healing process. When the surgeon removes the parotid gland, they are also severing all the tiny parasympathetic nerve endings.
These are the nerves that used to send the signal to the gland to secrete saliva whenever you eat.
Exactly. And as the surgical area heals over the following months, those severed saliva-producing nerves start to regenerate. They are desperately looking for a target to connect to.
But the salivary gland is gone.
Right. So in their confusion, they mistakenly attach themselves to the sweat glands in the overlying skin of the cheek.
So what does this all mean? It means a few months after surgery, you sit down to eat a delicious, mouth-watering piece of lemon cake.
And instead of your mouth watering, your cheek starts profusely sweating.
The signal gets completely crossed. It is exactly like a computer motherboard trying to solder itself back together after being smashed.
That's a great way to think of it.
It eventually works, it gets the power flowing, but occasionally